Good morning. Today we'll be discussing to you on the topic on hyperthyroidisms. Last time we discussed about hypothyroidism. They are both equally important for your clinical knowledge, as well as for your practice, as well as for your examination point of view. Both can come as as a long questions. So first, let us talk what do we mean by the term hyperthyroidism and thyrotoxicosis. So hyperthyroidism suggests that it is a result of excessive thyroid functions. So while thyrotoxicosis is defined as a state of thyroid hormone excess. Okay, so there is the difference between the two. Once when the functions of the thyroid has increased, that means it is mostly a disease of the thyroid gland itself, most of the time. And then thyrotoxicosis is defined as a state of thyroid hormone excess, not necessarily that due to the disease of the thyroid gland, but ultimately all causes of thyrotoxicosis, which also causes excess of thyroid hormones, excess due to the productions from the thyroid gland. So that is what it means by hyperthyroidism, which is excessive thyroid function. That means the function increases. And thyrotoxicosis, the state of thyroid hormone excess. So what are the causes of thyrotoxicosis? Thyrotoxicosis again, thyroid hormone excess. Okay. So when we say primary hyperthyroidism, that means it is a disease of the thyroid glands. So the most important causes of primary hyperthyroidism is Graves' disease. Then the others are toxic multinodular goiter, toxic adenoma, functioning thyroid carcinoma, activating mutation of the TSH receptors. Okay, when you have a mutation of TSH receptors, then it can mimic as an overstimulation of the TSH. Activating mutation of the GS alpha protein. This is a G protein coupled activations. The condition is known as the McCune-Albright syndrome. This is a genetic disorders, usually due to mutation of the protein G, and it affects the bone, the skin, and multiple endocrine glands. And in the thyroid, it usually causes hyperthyroidisms. The other features that you get in McCune-Albright syndromes can be the precocious puberty and the Cushing syndromes. Then the next cause of thyrotoxicosis is stroma ovari. Stroma ovari, as the name suggests, is the ovary. Ovary means ovary, plural for ovary. So it is a disease of the ovary. And stroma ovary means it is like a goiter of the ovary. So this usually you get when you have a tumor of the ovary, usually teratoma, which has the functioning thyroid tissue in it, and that is known as a stroma ovari. Drugs, for example, is the iodine excess, which is also known as the Jod-Bezdo phenomenon. So thyrotoxicosis without hyperthyroidisms, you can get in subacute, that means increased thyroid hormone without increase in functions. So subacute thyroiditis, silent thyroiditis. So other causes of thyroid destructions can be drugs like amiodarone, radiations, infarctions, and infarction of adenoma, ingestions of excess thyroid hormone, which is also known as thyrotoxicosis factitia or thyroid tissue. Okay. I hope you understand that ingestion of excess thyroid hormone. Excess thyroid hormone means in the person who is on treatment. It can be on their own with the clinician's support, or without taking by themselves, increasing the dose by themselves, or taking an excessive dose, or you take an ingestion of thyroid tissues. Is it possible that we are taking ingestion of thyroid tissue? Yes. A person who takes meat, for example, taking a neck tissues which contains the thyroid glands and the they tend to consume this every day, then this can have an effect on the thyroid and can cause thyrotoxicosis. Secondary hyperthyroidism, as the name suggests, secondary, remember last time when we talked about the primary, secondary. So secondary means outside of the thyroid gland. Okay, when it is outside of the thyroid gland. So as you know, that means the cause is due to the stimulation from above the thyroid. So what is the stimulation from above the thyroid? Mean it comes from the pituitary or it comes from the hypothalamus. So it can be a TSH secreting pituitary adenoma, or you have in a condition which is known as thyroid hormone resistant syndromes. When you have a thyroid hormone resistant syndrome, mean that the person is not responsive to the thyroid hormones, so they need a large amount of TSH to stimulate the productions, and this can increase the production of thyrotoxicosis. Chorionic gonadotrophin secreting tumors, like what we told earlier, and gestational thyrotoxicosis. That means during pregnancy, you can have also that changes in the thyroid gland is a normal physiology that you can get in case of pregnancy, and that is also known as a gestational thyrotoxicosis. Epidemiology, hyperthyroidism is a common disorder, but it is more common in female than in male, with a ratio of 5:1. The overall prevalence of hyperthyroidism is about 1.3%, which increases to 4 to 5% in older women. And hyperthyroidism is also more common in smokers. Graves' disease is commonly seen in younger women, while toxic nodular goiter is more common in older women. What are the clinical manifestations? So we can divide the clinical manifestation into overt hyperthyroidism. Overt means that it is clear cut. Okay, that means it comes to you with a frank symptoms which suggests that the patient is having hyperthyroidism. What are these symptoms? Are anxiety, emotional lability, weakness, lethargy, easy fatigability, tremor, palpitation, heat intolerance, increased perspiration or sweating, weight loss despite normal or increased appetite. However, we do get rarely that some patients may come to you with some weight gain. Many a time when the patient comes to us with weight gain, we always think that the patient could be having hypothyroidism. But to our surprise, many of times, we will see that it's suggestive of a mild hypothyroidism. That means you can get weight gain in patients of hyperthyroidism, provided it is a milder conditions, and this is due to excessive stimulation, appetite stimulations. So you can get weight gain if suppose you are asked in your oral exam, for examples, what are the features of hyperthyroidism? You will say weight loss with features of increased appetite. Suppose the examiner may cross question to you and say that, is it possible that you might have weight gain instead of weight loss and the biochemical parameters suggestive of hyperthyroidism? Yes, it is seen in conditions. It is seen in conditions where the hyperthyroidism is mild and it is common in younger individual. This is because of excessive appetite stimulations. The other features you can have is hyperdefecations. Many a times we get a patient who say that I have to pass motions many times in a day, but not necessarily diarrhea. That means diarrhea, it is not liquid, it is not watery. Urinary frequency, oligomenorrhea or amenorrhea in women, and gynecomastia and erectile dysfunction in men. Please note down these points that you can have changes in men as well in women when it comes to the genitourinary system. So you can have oligomenorrhea or amenorrhea in women and gynecomastia and erectile dysfunction in men. And remember that when we talk about hypothyroidism, we said that there is menorrhagia in case of hypothyroidism. In milder symptoms, patients with mild hyperthyroidism And older patients, usually they come to you depending, not, you will not have generalized symptoms like what you get in case of an overt hyperthyroidism, but it refers to what organ system is involved. Suppose if it affects the heart, then they come to you with palpitations, they'll come to you with abnormal beats, example like that. However, patients who comes to you, who may not have any symptoms, but who comes to you with unexplained weight loss, should be considered that hyperthyroidism could be a possibility. A patient who comes to you with new onset atrial fibrillations, myopathy, weakness of the muscles, menstrual disorders and gynecomastias, osteoporosis, hypercalcemia, heart failure, premature atrial contraction, shortness of breath, and a deteriorations in glycemic control in patients with previously diagnosed diabetes should be considered, and that the patient should be ruled out. I said that the patient should be ruled out that the patient may have coexistent hyperthyroidism. Older patients, many patients with older patients usually comes with cardiopulmonary symptoms like tachycardia, which is the most common one where you can have sinus tachycardia, or atrial fibrillations. Dyspnea on exertions and edema may predominate in older individuals. And older individuals tend to have more weight loss and less of an increase in appetite. However, there is a term which is known as apathetic thyrotoxicosis, which may come as a short notes. This one, apathetic thyrotoxicosis, or it may come to you in postgraduate entrance exams questions. What do you mean by apathetic thyrotoxicosis? This is a condition where the patients with hyperthyroidism do not have any symptoms except for weakness and asthenia. That is known as apathetic thyrotoxicosis. Subclinical hyperthyroidism. So when we have subclinical hypothyroidism, last time we diagnosed, it is we also have subclinical hyperthyroidism. Subclinical mean that the patient do not have any clinical features. However, the biochemical features, the thyroid estimation, the thyroid function test will tell us that there is some changes. So there will be normal clinical features. However, the serum TSH will be low with a low with a normal T4 and T3. These patients of subclinical hypothyroidism are having a threefold increase in the risk of atrial fibrillations if it occurs in older individuals. So remember last time we talked to you like when do we treat subclinical hypothyroidism? So the same here also, that which when we talk later about the treatment, that subclinical hyperthyroidism may be considered for treatment in some cases. A little bit about Graves' disease. Other than the symptoms which we have already discussed, there are some features which are seen in Graves' disease but which are not seen in other causes of hyperthyroidism. So this is not related to the high serum thyroid hormone concentrations. The Graves' features, the features which suggest that the hyperthyroidism is due to Graves' disease are Graves' ophthalmopathy and dermopathy. Then the other specific organ system manifestation that you see is the skin. The skin is warm. This is due because of it can be erythematous redness due to increased blood flow. The skin is smooth due to the decrease in keratin layer. The other changes that you see are sweating due to increased calorigenesis, onycholysis, that means loosening of nails from the nail bed. Hyperpigmentations, this usually can be associated because of the accelerated cortisol metabolism, because you know that hyperthyroidism, you can have increased metabolism. So usually mediated by accelerated cortisol metabolism. Pruritus and hives. Pruritus, that means itching, and hives mean that urticaria or rashes. This usually you see in patients with grave hyperthyroidism. Vitiligo and alopecia areata, these are usually features of autoimmune disorders. So thinning of hair, infiltrative dermopathy, okay? This is usually seen in the patient with Graves' disease, like the previous features that I show you. Look at the shin of the person. You will see that the overlying skin is raised, hyperpigmented, violaceous, orange peel texture, and that is known as the Graves' thermopathy. The eyes, what are the eye changes that you see? Staring look and lid lag occurs in all patients with hyperthyroidism. This is due to sympathetic overactivity. However, the eye changes, which is specific to Graves' disease or Graves' ophthalmopathy, is characterized by inflammation of the extraocular muscles and orbital fat and connective tissues, because of these inflammations, there will be the proptosis, impairment of eye muscle functions, and periorbital and conjunctival edema. Ophthalmopathy is more common in patients who smoke cigarette. Since the patients with ophthalmopathy may also have a gritty feeling or pain in their eyes, this is because of the what we know as exposure keratitis, due to feeling of gritty sensation. Gritty feeling mean as if the foreign body is there, or as if there's a sand in your eyes. So that is a gritty feeling of pain. They'll be painful because of inflammations of the cornea. That is known as exposure keratitis. And then when you recollect when you talk about keratitis, the pain, gritty sensation, pain, redness, these are the signs that usually due to keratitis. So, however, in Graves' disease, it is due to exposure keratitis. That means the eyes are not closing, so because of exposure, and there will be dryness and there will be inflammations. However, in severe cases, corneal ulcerations can also occur. Cardiovascular changes, cardiovascular system manifestation, you can have increase in cardiac output. This is due to increased peripheral oxygen needs and increased cardiac contractility. Because of increased metabolism mean that all tissues, they require oxygens. So there will be increased oxygen requirement, and because of that increased oxygen requirement, there will be increased cardiac contractility. It's just like when you're running, when you exercise. When you're exercising, what happens is the tissues, especially the muscles, will require a large increased oxygen consumptions. They'll require oxygen, so the heart will pump faster and quicker and stronger. Heart rate is increased, pulse pressure is widened, and peripheral vascular resistance is decreased. So see the point here that you see is the heart rate is increased. There will be tachycardia. The pulse pressure is widened. I hope you understand by the term pulse pressure is widened, and peripheral vascular resistance is decreased. Systolic hypertension is common, so I understood only when you say that pulse pressure is widened, that means there is the widened pressure between the systolic and diastolic. So high or normal output congestive heart failure is seen. Atrial fibrillation occurs in 10 to 20% of patients, and it is more common in older individuals. In 60% of the patients with atrial fibrillations, the rhythm converts back to normal on treatment. The other abnormalities that you can get, this is important because usually not rarely discussed or given in all books, is that you may be asked in your oral exam, what is the most common cardiac manifestation of hyperthyroidism? The answer should be sinus tachycardia. So in addition to sinus tachycardia, you can have atrial fibrillations, and you can have other features like mitral valve prolapse, mitral regurgitations, and increase in left ventricular mass index have also been reported. Bone. What are the features that you see in bone? Changes in the bones. Thyroid hormone stimulate bone resorption. This is important that is this one reason that we have to treat hyperthyroidism, is because it causes bone resorptions. When it causes bone resorption, there will be weakness of the bones. So what are the features of increased bone resorption? There will be increased serum alkaline phosphatase and osteocalcin. Okay, that is they are indicator of increased bone turnover. The increased bone resorptions lead to increase in serum calcium. And because of the increase in serum calcium, it inhibits parathyroid hormone secretion and thereby preventing the absorption of calcium. At the same time, there is a decrease of consumptions of the inactive to active vitamin D. So the net effect of this that you see in bones are osteoporosis and an increased fracture risk in patients with chronic hyperthyroidisms. So Graves' disease may also be associated with thyroid acropathy. Acropathy means is a dermopathy which you get in thyroid in Graves' disease. That is not when a dermopathy when you get in Graves' disease. Usually, the term can also be called as thyroid acropathy. Here you will get clubbing. So clubbing, you should remember that clubbing also can be seen in case of Graves' disease. Periosteal new bone formations in the metacarpal bones of phalanges. Patients with thyroid acropathy commonly they present with asymptomatic clubbing, severe ophthalmopathy, and dermopathy. Other dermopathy. Serum lipids, there is usually a decrease. Remember, when we talk of hypothyroidism, we remember of increased cholesterol, increase this one what you know as. There is dyslipidemia in case of hypothyroidism, but in case of hyperthyroidism, there is the opposite of dyslipidemia. You have instead a low serum total as well as a low HDL and low LDL cholesterol. Hyperglycemia can also be seen. Remember that hyperthyroidisms usually can interfere with glucose metabolism. This is usually because there is an increased sensitivity of pancreatic beta cells to glucose, resulting in increased insulin secretion, and at the same time, an antagonism to the peripheral actions of insulin. And because of the antagonism to the peripheral action of insulin, insulin is supposed to, when we discuss about diabetes mellitus, we said that the glucose which is there in the blood is supposed to be absorbed by the peripheral tissues. What are the tissues that we usually affect for the blood sugar, the insulin actions? The muscles, the fat, and the liver. Here, the muscles and the fat, the sugar is not going inside because of antagonism to peripheral action of insulin. So insulin is not functioning properly. So that's the reason there will be an increased blood sugar level. This can lead to impairments of blood glucose, especially in the patients who are diabetic, where you will see that there is changes and the patients do not have a proper control of diabetes. Adrenal functions, the interpretation of the cortisol response to corticotrophin, ACTH stimulation tests may be misleading in patients with hyperthyroidism. So that means the ACTH stimulation test may be misleading in patients with hyperthyroidism because cortisol binding globulin level decrease, which resulting in lower serum cortisol concentrations. Respiratory system, there will be dyspnea and dyspnea on exertions. Why dyspnea and dyspnea on exertions occur? This is because there is an increased oxygen requirement, and because of increased requirement, there is increased oxygen consumption. And in addition, what will happen when you have increased consumption of oxygen? Carbon dioxide productions also increase. This results in, because of the increased demand of oxygen, there can be hypoxemia, and there can be hypercapnia, which stimulates, and you know hypercapnia is the single most important stimulant for ventilations. At the same time, you can have respiratory muscle weakness and reduced exercise capacity due to respiratory muscle weakness and decreased lung volume. There may be tracheal obstruction from a large goiter. Is it possible? Yes, possible. You can have dysphagia. You can have stridor also. So difficulty in breathing can be there. So hyperthyroidism may also exacerbate the underlying asthma, and there can be pulmonary arterial systolic hypertension. Gastrointestinal changes, weight loss is primarily due to increased metabolic rate and secondarily to increased gut motility and the associated hyperdefecations and malabsorptions. Celiac disease is also more prevalent in patients with Graves' disease. Most patients have hyperphagia. Some patients with mild hyperthyroidisms may have sufficient appetite stimulations that weight is gained instead of loss. Anorexia may be prominent in older hyperthyroid patients. Other changes that you may see in the gastrointestinal symptoms is vomiting and abdominal pain, rare. Dysphagia, possible if the goiter is very large. Abnormalities in liver functions, particularly high serum alkaline phosphatase concentrations, and rarely cholestasis can also be seen. The thyroid size, the presence of a goiter depends upon the cause of the hyperthyroidism. That means all patients with hyperthyroidism do not have enlargement of the thyroid gland. The thyroid enlargement ranges from minimal to massive in patients with Graves' disease or toxic multinodular goiter. A non-palpable thyroid occurs commonly in older patients with Graves' disease. Patients with painless thyroiditis may have no minimal or modest thyroid enlargement. The absence of any thyroid enlargement should also suggest exogenous hyperthyroidism or stroma overi. I will discuss this point again when a little bit about exogenous hyperthyroidism. I will repeat the same point here, that the absence of a thyroid enlargement. First, I said just now that not necessary that all patients with hyperthyroidism will have thyroid enlargement. Now, there is a point also that in a patient with exogenous hyperthyroidism, the thyroid is never enlarged. So that is a point which, again, for your postgraduate entrance exam as well as for your oral examinations, in case you get a short case, or not only in medicines but also surgery and TE. So the examiner may ask you, can you tell one point that will tell that the hyperthyroidism is not due to a disease of the thyroid gland, but rather due to excessive consumption of thyroid tissues or medications. So it is the absence of a thyroid swelling. The thyroid is painful and tender in subacute thyroiditis. Many patients, you will get these patients in your day-to-day activity. Thymic enlargement, rare, but yes, possible, usually is seen in Graves' disease, where the thymus gland is enlarged. The thymus gland is usually discovered incidentally because, as you know, that the thymus is inside the thoracic cage. So usually we will not suspect that the patients will have the thymus enlargement, thymus gland enlargement. However, when they come to you with dyspnea or difficulty in breathing, when you evaluate such patients, you may discover incidentally these patients. Pathogenetic mechanism of thymus enlargement is not clear, other than Graves' disease. And because it is seen only in Graves' disease, so it has been postulated that it is due to autoimmune in nature. Treatments of Graves' disease with antithyroid medications, radioiodine, or thyroidectomy result in involutions of thyroid hyperplasia over 4 to 25 months. Hematological changes. The red blood cell is increased. Red blood cell mass is increased in hyperthyroidism. So that is one point. If you have an increase in red cell mass, you are supposed to have more hemoglobin. But the opposite happened. But the plasma volume is also increased. So what happened here? This ultimately results in normochromic normocytic anemia. So there is an increased cell mass, increased red cell mass, but at the same time, there is an increased plasma volume. For that reason, there is the thing is balanced. Most of the time, it is normochromic normocytic anemia. So serum ferritin concentrations may be high. In Graves' disease, you may have other autoimmune hematologic disorders such as ITP and pernicious anemia. And some patients may have anti-neutrophilic antibodies. Hyperthyroidism may be also prothrombotic because there is excess. The excess thyroid hormone has also been associated with a rise in prothrombotic factors, including factor 8, 9, fibrinogen, 1 Willebrand factor, and plasminogen activator 1. Genitourinary, patients can come to you with nocturia, and the mechanism is uncertain. The possible cause include primary polydipsia and hypercalciuria. Enuresis is common in children, where the patient can have bedwetting at night. In women, sex hormone binding globulin concentrations are high. So when you have sex hormones binding globulins are high, this results in high serum estradiol concentrations and low normal serum, low or normal serum free estradiol concentrations. There will be high luteinizing hormone concentrations, a reduced mid-cycle surge in LH secretions, and because of that, there will be oligomenorrhea and anovulatory high infertility. Amenorrhea can occur in women with hyperthyroidism. In men, the increase in sex hormone binding globulin results in high serum testosterone concentrations. If you have high testosterone concentrations, then why should you have low libido or gynecomastia? So now the point is, because in spite of that, but serum-free testosterone concentrations are normal or low. That is the point. At the same time, serum luteinizing hormone concentrations may be slightly high. That is the one. Extragonadal conversions of testosterone to estradiol is increased. And this that means so that the serum estradiol, that means the estrogens concentrations are high. And because of the increased concentrations of estradiol or estrogen, it causes gynecomastia, reduced libido, and erectile dysfunction. Spermatogenesis is often decreased or abnormal, and that means spermatozoa are abnormal or non-motile. Neuropsychiatric, behavioral, and personality changes, anxiety, restlessness, irritability, emotional lability. This is what we talked earlier about the overt hyperthyroidism. Insomnia is also common. However, the symptoms are often worsened in patients with pre-existing psychiatric disorders. Behavioral manifestations are accompanied by cognitive impairment. Particularly, you get impaired concentration, confusion, poor orientations, and immediate recall, amnesia, and constructional difficulties. Thyrotoxic periodic paralysis. You have heard of this term, periodic paralysis. Here we have thyrotoxic periodic paralysis, rare presentations of thyrotoxicosis. There is marked muscle weakness associated with hypokalemia, frequently precipitated by exercise, fasting, or a high carbohydrate meal, and seen most frequently in Asian males. What are the investigations that you will do? Definitely you will do a TSH, T3, and T4. Thyroid function tests. All patients with primary hyperthyroidism will have a low TSH. The serum low TSH concentrations alone cannot determine the degree of biochemical hyperthyroidism because TSH can be low in overt as well as in subclinical hyperthyroidism. What is that? That is what it means by TSH concentration alone cannot determine the degree of biochemical hyperthyroidism. You will require a serum-free T4 and T3 to provide this information. Most patients with overt hyperthyroidism have values of TSH less than 0.05. Many patients with overt hyperthyroidism have high free T4 and T3 concentrations. In some patients, however, only the serum T3 or serum T4 is elevated. In patients with subclinical hyperthyroidism, TSH is below normal, but usually it's not as low as in overt hyperthyroidism, and usually the TSH value is always more than 0.05 microunit per liter. And serum free T4 and T3, serum free T4, T3, and free T3 are normal. The other laboratory test that you'll do is the low serum total, low density and high density lipoprotein, cholesterol low, increased red cell mass and increased plasma volume. There will be normocytic, normochromic anemia. There is increased alkaline phosphatase and osteocalcin because of increased bone turnover. There is a term which is known as T3 toxicosis. So what does it mean here? That means the T3 is high. Most patients with overt hyperthyroidism usually have an increase in serum T3 than in serum T4 due to a disproportionate This can happen in disproportionate increase in thyroidal T3 secretions as well as an increased extrathyroidal conversions of T4 to T3. So patients with hyperthyroidisms may have TSH low, but the T4 will be normal, the T3 will be high. If you have an isolated T3 without an increase in T4, that is known as T3 toxicosis. The other also happen. I mean, instead of T3 toxicosis, you will have T4 toxicosis. This is again the same. But the way you have TSH usually will be always low, but the T4 will be high here, but the T3 will be normal. So this is usually what is known as a T4 toxicosis. Evaluations of thyrotoxicosis. When a patient comes to you with thyrotoxicosis, you measure the TSH and the unbound T4. The T4 is a test which you will prefer to do. If the TSH is low, the unbound or the unbound mean free T4 is high, that means it's clear cut that the patient is having primary thyrotoxicosis. Then you go further down and see whether there are features of Graves' disease. If the answer is yes, then it is Graves'. If the answer is no, then it could be a multinodular goiter or toxic adenoma. If the answer is yes, then toxic nodular hyperthyroidism. If the answer is low, you do a radionuclide scan. If a low radionuclide scan intake, if it is yes, then it is destructive thyroiditis, iodine excess, or excess thyroid hormone. Rule out, if it is no, then you rule out other causes, including stimulation by chorionic gonadotrophin. This I took from Harrison. So you can see from there if you want to see. Measure the TSH is low, the FT4 is normal. So that means you measure the T3. If it is high, it is T3 toxicosis. Normal, then it is subclinical hyperthyroidism. Follow up in 6 to 12 weeks. If TSH is normal or increase in free T4, then it is TSH secreting pituitary adenoma or thyroid hormone resistance syndrome. The other is TSH and T4 is normal, then no further test, that means it is a normal state. The treatment, how do you treat? The treatment, number one is, what are the goals that you would like to achieve when you treat a patient with hyperthyroidism? Is number one is ameliorations of symptoms. I mean, you want the patients to be symptoms free. You want to normalize the serum TSH level. The drugs which can be used for the treatment of hyperthyroidism are beta blockers, antithyroid medications, iodine, radioiodine, and surgery. Symptoms control, beta blockers, here we say that beta blockers. Beta blocker has nothing to do with the thyroid hormones, but however is a most important drug which we usually give as the initial period when the patient comes to us with symptoms of hyperthyroidism. So beta blocker to be started. Okay, however, you have to know that the patient is not having a contraindication, absolute contraindications to beta blocker use. In most patients, this is the first drug that it is used. These drugs dramatically cause reductions in the symptoms of hyperthyroidism. The symptoms that are usually being relieved by beta blockers are the symptoms that are due to increased beta adrenergic tone. These include palpitations, tachycardia, tremulousness, anxiety, and heat intolerance. The next is how to decrease the thyroid hormone synthesis. What are the drugs that are available? We have the antithyroid drugs, most commonly used drugs, radioiodine, and surgery. You have to know that all these three are effective. However, they all have significant side effects. Antithyroid drugs may be used initially to control hyperthyroidism prior to definitive therapy with radioiodine or surgery. Okay? Radioiodine may be given as initial therapy or after pretreatment with antithyroid drugs. We will discuss in which conditions. Surgery is usually preceded by antithyroid drugs to attain a euthyroid state preoperatively. What are the drugs that are used commonly are methimazole, 5 to 30 milligram daily, propylthiouracil, 100 to 300 milligram per day, can be given in 2 divided or 3 divided doses. These drugs, as they are known as anti-thyroid drugs. Anti-thyroid mean they inhibit the synthesis of thyroid hormone. How do they do that? They do this by interfering with iodination of tyrosine residues. Then the effect usually of the decrease in thyroid hormone synthesis seen in 1 to 2 weeks after initiation of therapy. That is one of the most important points. And when you diagnose a case of hyperthyroidism, usually beta blockers are the ones that act fast. They act with faster onset of actions, and that's why the patients usually recover from the symptoms that are due to hyperthyroidism, even before the reductions in the synthesis of the thyroid hormone. So the side effects that you can get with antithyroid drugs are rash, arthralgia, nausea, vasculitis, liver function test abnormalities. Liver failure has also been reported with PTU, agranulocytosis, embryopathy. So agranulocytosis means that there is severe reductions in case of the leukocytes. So you have to check the baseline CBC and liver function test. The baseline before starting the drugs, number one. Number two is whenever you call them for follow-up, you have to check these tests. If you're giving an methimazole, carbimazole, then usually we do hemoglobin and TSH, DLC. But if the patient is getting PTU, we have to check the liver function test. Methimazole, primary use in Graves' disease, is not considered first-line therapy for toxic nodular goiter. The chances for remissions is euthyroid, expected that the patient will become a normal thyroid functions or euthyroid states. That means 1 year after treatment cease. More likely in smaller goiter, milder disease, lower antibody titer. Pretreatment of patients awaiting radioiodine therapy or surgery. If the patient can be given for pretreatment with patients awaiting for radioiodine and surgery, but you have to stop this 3 to 5 days prior to radioiodine. It is once daily dosing, 5 to 30 milligram per day. Monitor the lab every 4 to 6 weeks initially. Free T4, T3, TSH suppression can lag for months. What it means that whenever you change the dose of the thyroid medications, you do not see and you do not test every week. The minimum that usually do is preferably 6 weeks, that means 1.5 months. Remember last time we talked to you about hypothyroidism, I said that usually we do after 6 weeks to know the level. But however, in pregnancy, where we want to have, where we want to know the level earlier, we used to do every 4 weeks. So the first changes that you see is not the TSH, it is the reduction in T4, free T4, T3, but the TSH suppressions usually takes longer time to be seen. Treat usually for 12 to 18 months. Okay, radioactive iodine. Beta blocker is usually given along with it, peritherapy. Pregnancy is an absolute contraindication to radioactive iodine treatment. In Graves' disease, the goal is you should have hypothyroidism after treatment. Fixed dose or calculations depending on the weight. The toxic multinodular goiter and toxic adenoma can be euthyroid following treatment. May repeat in 6 months if initial dose is ineffective. Is effective, not effective. Surgery. May need pre-op operation with supersaturated potassium iodine, that is usually done in surgery here, to decrease the vascularity of the gland. Continue antithyroid medications and beta blocker. Levothyroxine replacement following surgery may be required, especially in case of total thyroidectomy. Total thyroidectomy for Graves, partial for possible for toxic nodular goiter. Hyperthyroidism during pregnancy. The important issues is that you have to know the understanding of indication for treatment. Not all patients may have. Therapeutic options available. The goal of antithyroid drug therapy. What are the goal of treatment for hyperthyroidism? A good fetal and maternal outcome. However, you should, before treating a patient with hyperthyroidism in pregnancy, you have to know that there are certain changes in thyroid physiology during normal pregnancy that are reflected in altered thyroid function tests. The thyroid function tests they are supposed to be interpreted with an understanding of the trimester specific reference ranges for the individual tests. The goal of treatment is to maintain persistent but mild hyperthyroidism in mother. See the point. The goal of treatment is to maintain persistent but mild hyperthyroidism in the mother to prevent fetal hypothyroidism. No, you don't want the mother to go to, you want to be a very subclinical type of hyperthyroidism changes here. This, you don't want the patient to go to to have fetal hypothyroidism, since the fetal thyroid is more sensitive to the action of the antithyroid drugs. Overtreatment of maternal hyperthyroidism with thionamides can cause fetal goiter and primary hypothyroidisms. You have to keep that in mind. The transient central hypothyroidisms may be seen in infants whose mother had poorly controlled hyperthyroidism due to suppressions of the fetal pituitary thyroid axis. Indication for treatment: overt hyperthyroidism. Patients will not all patients with biochemical overt hyperthyroidism require treatment if the hyperthyroidism is mild. I will not go about the level here. So overt hyperthyroidism due to Graves' disease, toxic adenoma, toxic mononuclear goiter, or gestational typhoblastic disease are indications for treatment with antithyroid drugs. However, not all patients required if they are mild. Treatment of hyperthyroidism is not required in the following setting in pregnancy: transient subclinical hyperthyroidism, normal serum total of free T4 concentration for pregnancy in the presence of a subnormal TSH in the first trimester of pregnancy, because it is considered a normal physiologic findings and therefore does not require therapy. Important. So HCG-mediated overt hyperthyroidisms, also called as gestational transient thyrotoxicosis, is not required for treatment because it is usually transient and mild. Hyperemesis gravidarum associated hyperthyroidism again is not required because it is usually mild and subside as HCG production falls. Subclinical and mild asymptomatic overt hyperthyroidisms due to Graves' disease, adenoma, or toxic multinodular goiter do not require. In women who are being monitored without therapy, measure TSH pre-T4 if there is a trimester specific reference range. Usually you can ask for this from the lab, that for pregnancy, what is the trimester reference range? Okay. This is done every 4 to 6 weeks. What are the therapeutic options in case of pregnancy or a patient who is about to get pregnant? Depending actually on you have to discuss this with the patients. What are the treatment that they want, and then the response at the same time that surgery also can be considered. However, like any other conditions, surgery in pregnancy is usually done in the second trimester. The drugs that are usually taken into consideration for the treatment in pregnancy is thionamides. Beta blockers is not a contraindications. However, long-term treatment with beta blocker longer than 2 to 6 weeks should be avoided, because what I said earlier is that you give beta blocker, control the symptoms, they give antithyroid drugs, they reduce the productions of the thyroid hormone, the symptoms subsided, and you can withdraw the beta blockers. Especially in pregnancy, you don't want to give longer, is because there is a concern regarding the fetal growth retardations, hypoglycemia, and especially this is with atenolol. Thyroidectomy during pregnancy is rarely necessary, but is an option for women who cannot tolerate thionamides because of allergy or side effects like agranulocytosis. The other treatment options in pregnancy is plasmapheresis, has also been used to rapidly control hyperthyroidism in women with trophoblastic disease and severe hyperthyroidism. Choices of thionamides available are PTU, methimazole, and carbimazole. The choice of the drugs depend on which trimester. Methimazole is preferred to PTU except during the first trimester of pregnancy. If a patient is diagnosed prior to pregnancy, if suppose the woman is diagnosed with Graves' disease or other hyperthyroidism before pregnancy happened, elect to have a definite therapy with surgery or radioiodine prior to pregnancy. Switch to PTU before trying to conceive. Switch to PTU as soon as a pregnancy test is confirmed. Discontinue metimazole with careful monitoring of thyroid function tests. Whenever you suppose the patient is taking metimazole, become pregnant, you switch over to PTU. However, whenever you switch the patients from metimazole to PTU, it has to be given at a lower dose and it has to be properly monitored. Okay. A patient taking PTU during the first trimester may continue it for the remainder of the pregnancy or switch back to metimazole at the start of the second trimester. Diagnosed during the first trimester, women diagnosed with symptomatic moderate to severe hyperthyroidism during the first trimester of pregnancy should take PTU. Patient may continue PTU for the remainder of the pregnancy or switch back to metimazole. Metimazole is more potent than PTU. That is the point which I want to tell you, that metimazole is more potent than PTU. Switching from metimazole from PTU to metimazole, you have to give a lower dose, as this may have an increased risk of maternal or fetal hypothyroidism. If the patient is diagnosed after the first trimester, women diagnosed with symptomatic moderate to severe hyperthyroidism after the first trimester should take metimazole. The initial dosings, usually we give at lower dose, PTU at 50 milligrams, metimazole 5 to 10, carbimazole 5 to 15 daily. In patients with severe hyperthyroidism, full initial doses of PTU, that means 100 milligram 3 times a day, or metimazole 10 to 30 milligram daily, may be required to control hyperthyroidism. For patients switching between PTU and metimazole, the closest dose approximation should be made. This is what means that metimazole is 20 to 30 times as potent on a milligram to milligram basis. So that is the one that I told earlier, is that metimazole is more potent than PTU. So 300 milligram of PTU would be roughly equivalent to 10 to 15 milligram of metimazole. If the patient is taking 300 milligram of PTU, then you can give metimazole 10 to 15 milligrams. Postpartum issue, breastfeeding. Usually PTU is avoided in postpartum state. This is because of long-term use can associated with hepatotoxicity. Metimazole is usually preferred in divided doses. When the maternal doses of metimazole is more than 20 milligram daily, infant should have thyroid function tests assessed after 1 and 3 months to make sure that they don't go into hypothyroidism. PTU is less soluble than metimazole and is more bound to plasma proteins. Metimazole is free in serum. The relatively more metimazole reaches the infant via breast milk. However, it is not a contraindication to breastfeeding. There is a little difference in serum thyroid hormone concentrations or thyroid functions in infants of mother given moderate doses of either drugs, and no report of agranulocytosis of liver disease in an infant nursed by a woman taking PTU or metimazole. So that means PTU as well as metimazole can be used. However, PTU is not preferred as long-term use can affect the liver. Metimazole, though it can reach the breast milk, however, is not a contraindication, and it has not been reported that the patient severe side effect has not been reported in infants who have been nursed by mothers taking PTU or metimazole. A little bit about exogenous hyperthyroidism. As the name suggests, exogenous means coming from outside, nothing to do from the body. Exogenous hyperthyroidism is a term used to describe hyperthyroidism caused by ingestions of excessive amount of thyroid hormones. It may be intentional, that is, suppressive doses of thyroxine to treat thyroid cancer, or inadvertent, that is, contamination of dietary supplements. Inadvertent, that means unknowingly, the patient has been given some drugs. For example, nowadays, you have a lot of advertisement where people want to lose weight, and over the counter or online, where you get these advertisement which props in every time to weight loss. These dietary supplements has been detected to have a lot of hormones supplements. So when exogenous hyperthyroidism is due to surreptitious ingestions, that means surreptitious ingestion, then that is known as thyrotoxicosis factitia, that means given thyroid drugs. How does exogenous hyperthyroidism occur? Ingestions of excessive amount of thyroid hormones occur because usually it can be a patient with thyroid cancer, We want to reduce the functions of the thyroid. The patients with goiter who will prescribe doses to shrink the thyroid glands. Other patients with or without the help of clinicians take excessive dose to treat obesity, mental disorders, depressions, or infertility. Patient who intentionally or accidentally take an overdose of thyroid hormone. Accidental overdose has also been described in adults taking weight-reducing dietary supplements. A novel form of exogenous hyperthyroidism is the ingestion of thyroid tissue inadvertently removed and ground out with neck muscles in slaughterhouses to prepare hamburger. This is reported in the West, which is known as, with a term given as hamburger thyroiditis. The diagnosis of exogenous hyperthyroidism is clinical features is the same. Laboratory findings can be the same. 24 hours radio iodine uptake, however, will tell you what it is. Patients with exogenous hyperthyroidism have classic biochemical changes, which is the same like hyperemesis. However, the absence of a goiter, a low serum thyroglobulin, and a low or detectable 24 hours iodine uptake differentiate exogenous hyperthyroidism from other causes of hyperthyroidism. That means clinical features same like the other causes of hyperthyroidism. Laboratory findings same. However, the goiter, low thyroglobulin, and low iodine uptake is usually seen only in exogenous. That means in absence of a goiter, low thyroglobulin and low iodine uptake means that the patient is having exogenous hyperthyroidism. Mark this point, these 3 points which I'm giving in the last. The exogenous hyperthyroidism is seen, the following is seen in high exogenous, except, so they may ask you, absent of goiter, low thyroglobulin, low or undetectable 24 hours iodine uptake. So this can be seen. Graves' ophthalmopathy, what do we do? Is there any treatment for that? Yes, up to 50% of patients with Graves' disease may have eye involvement. Some patients can, even after they become euthyroid or hypothyroids, you can still see that the ophthalmopathy. You can give high dose steroids has been used, radiation has also been used, surgery has been used, orbital decompression, selenium, other supportive therapy like lubricants, prisms, etc. Lubricants like to prevent exposure keratitis, alternative therapy like rituximab and Botox. Okay, I think this is the last slide here. Okay. Okay, thank you.